Hi, my name is Payal Patel, and I'm going to be talking to you today about Clostridium difficile infection and antibiotic stewardship in nursing facilities. I'm an infectious disease physician at the University of Michigan and the medical director of antimicrobial stewardship at the VA hospital in Ann Arbor, where we also have a long-term care unit as a part of our hospital. In this talk, we'll be discussing the problem of C. diff and some steps that we can take to prevent its spread in nursing care facilities and how an antibiotic stewardship program can stop C. diff. We will also discuss a case and finally the take-home points from this talk that I hope will stay with you. C. diff is actually the most common healthcare-associated infection, and in the populations that are seen in nursing facilities like the elderly, C. diff often has higher morbidity and mortality, meaning it lasts longer and it is more likely to cause death. Immunocompromised patients also have a tougher time with C. diff infections and tend to have worse symptoms, longer course of infection, and higher chance of death. When an outbreak occurs, incidence rates of C. diff can increase five-fold, meaning perfect environmental cleaning is a must to stop the spread. One of the reasons we've had so much more C. diff in the US and worldwide is due to the emergence of a particularly hypervirulent strain. And altogether, C. diff costs the US upwards of $5 billion a year, so improving how we do with C. diff could greatly impact the health of our patients and save our healthcare system money as well. As you can see here, C. diff rates per 1,000 discharges have risen through 2013, though it sounds like the most recent data that is yet to be released from the CDC shows some national improvement in rates. Again, remember C. diff is especially tough for patients over 65. The two most important risk factors associated with getting C. diff are getting antibiotics and being over 65. And if you do get C. diff and you're over 65, you're more likely to have a bad outcome, like severe CDI, death, or recurrence of C. diff infection. So what's the best way to prevent C. diff? The best way to prevent C. diff infection is preventing the infection from even taking place by using antibiotic stewardship. That means ensuring patients are only getting antibiotics when they truly need them. As you all may know, in the last year, antibiotic stewardship programs have become mandated by the Centers for Medicare and Medicaid because they are proven ways to improve patient care and are sorely needed in the nursing facility arena. Here's one example of how stewardship can prevent C. diff. This paper described a community hospital that had a C. diff infection outbreak, and their hospital went to complete fluoroquinolone restriction. You see a sharp decrease in C. diff cases, and it stayed steady as well. At our VA hospital, we have had a complete restriction on fluoroquinolones, and this includes moxifloxacin, ciprofloxacin, and levofloxacin for decades. And our C. diff rates compared to other hospitals are much lower, and we do believe this is a primary reason as to why. One of the main reasons antibiotic stewardship programs are needed is because we overprescribe antibiotics. In fact, we do it so much that up to 50% of antibiotic prescriptions are either unneeded or inappropriate. And that's important because antibiotics have side effects. You know that they cause C. diff, but they also increase your patient's risk of an invasive fungal bloodstream infection. They can cause antimicrobial resistance for the patient you're taking care of, but can also affect others living around that patient. And there are more than 140,000 ER visits a year for adverse drug reactions ranging from a mild rash to DRESS syndrome. Last time I was on ID consults, I got a consult from the hospitalist that was worried about a 22-year-old young man who was prescribed an extended course of Bactrim at an urgent care center for what turned out to be a likely viral infection. He presented with edema, he was bright red from head to toe with liver enzyme abnormalities and eosinophilia. He was found to have DRESS syndrome. he was admitted to the hospital and seen by 3 consulting services, hematology, dermatology, and ID, for what could have likely been an avoidable admission. And that's just one of the 140,000 stories. And it's not just getting the drug. The duration also seems to increase your chances of developing C. diff infection. This study from Quebec was done after an outbreak of CDI in more than 30 hospitals. They were trying to figure out if PPIs were increasing risk of CDI, but what they found was it was clear that fluoroquinolones were most strongly associated with C. diff, and the risk seemed to go up the longer a patient was on antibiotics. There's a particularly urgent need for stewardship in the long-term care setting, which led to the mandatory requirement for stewardship programs last year. Up to half of residents in a long-term care facility may be colonized with C. diff, making them higher at risk for this infection. And we know that almost half of all antibiotics may be unnecessary. And given that elderly patients are at a higher risk for worse C. diff outcomes, this is why stewardship is so important in this setting. Now I want to go over a quick stewardship case and show you how stewardship can be used in daily practice. Let's say an 82-year-old woman who is at your facility is found to be acting funny. She has a history of hypertension, coronary artery disease, diabetes, congestive heart failure, gout, Lewy body dementia, and was in the hospital recently for a heart failure exacerbation. She's afebrile, but has a temperature of 99.1. She's not tachycardic, but has a heart rate of 97, and her blood pressure is stable and at her baseline. Here are her labs. So far, blood cultures have been sent and are pending, but the urinalysis comes back quickly, showing cloudy, turbid fluid with positive nitrates and positive Luc esterase. Her troponins are negative, and her liver enzymes are within normal limits. What do you think would happen at your facility next? Would your team likely start an oral antibiotic for a possible urinary tract infection? Would your team start an oral antibiotic and give IV fluids? Or would your team start IV fluids and hold off on antibiotics? This is called watchful waiting. I want you to take a second and think about this. I would say the watchful waiting tactic is a stewardship move. This patient could have a number of reasons that she is feeling funny, including dehydration. And without symptoms of dysuria or fever, this is likely asymptomatic bacteriuria, which should not be treated with antibiotics. I encourage you all to think about this case and be mindful the next time you are faced with a dirty urine, especially when the patient does not endorse any symptoms. So what are the take-home points from this talk? Stewardship programs are new in the nursing facility area, and it would be easy to just check the boxes administratively and say you have a stewardship program. But to really prevent C. diff and improve patient outcomes, the stewardship program has to really work at a few things. I've provided a few fairly straightforward starting points. One is that restricting fluoroquinolones, which now have an FDA warning anyway because of things like QT prolongation and tendinitis, can significantly impact your C. diff rates in the right direction. You can also focus on not treating asymptomatic bacteriuria. This could have a particularly large impact at nursing facilities. We're working on this now at our VA hospital along with other VA hospitals in collaboration. And if faced with a patient who may have a mental status change, consider watchful waiting. Finally, having your stewardship team focus on duration of antibiotics could impact how many unnecessary antibiotics are being prescribed. Other stewardship techniques may include focusing on things like avoiding double anaerobic coverage of antibiotics or trying to reduce unnecessary IV meds when they're equally bioavailable as oral formulations. One last point that will be addressed in an upcoming educational module is the importance of environmental cleaning and hand hygiene to stop the spread of CDI. Remember that environmental cleaning and hand hygiene are very important in stopping the spread once CDI has started. Use disinfection products that kill spores, such as sporicidal agents. Encourage soap and water hand hygiene for all healthcare workers. Review daily and terminal room cleaning and disinfection process, and consider an audit and evaluation of that process. Educate and encourage those responsible for cleaning and disinfection, and we probably vastly underestimate how much asymptomatic carriers of CDI matter. Remember, be proactive rather than reactive. Thank you so much.